All right, let's jump right in. For a hemodialysis patient, that needle stick, it's so much more than just a routine part of treatment. It's actually a moment of incredible precision, a skill that directly, and I mean directly, impacts the health of their lifeline. So today, we're going to pull back the curtain on the hidden craft of cannulation. We're talking about the technique that, when it's done right, is what keeps that vital connection flowing. So what is this lifeline we're talking about? It's called an arteriovenous fistula, or AVF for short. And the best way to picture it really is like a surgically created superhighway for blood built right under the skin. It connects an artery and a vein, usually in the arm. Now, there's a reason it's called the gold standard for dialysis access. It's because it's literally built to last. It's the most durable, most reliable option a patient can have. Okay, so if this thing is the gold standard, the best option we've got, then why do they sometimes fail? And believe me, the stakes are incredibly high. A failed fistula isn't just a small problem, it's a huge setback for a patient. And you might be surprised to hear this, but the answer? Well, it often comes down to the skill of the person holding the needle. Yeah, getting the cannulation wrong, it's not a minor mistake. We're talking about really serious issues. You could get venous stenosis, which is a narrowing of the vein, infiltration, where blood leaks out into the tissue around it, or even an aneurysm, a dangerous bulge in the vessel wall. And the real-world consequence of this, it's pretty stark. Just one of these problems can mean a patient is stuck using a high-risk catheter for an average of 3 extra months. That's a huge deal. All right, first up, a lifeline under the skin. We're going to dig into understanding the gold standard for a healthy fistula. Because really, how do we avoid all those nasty complications? Well, it all starts with knowing what to look for, understanding the signs of a healthy, ready-to-use fistula before a needle ever comes close. And you know what's crazy? The key to this whole assessment, it pretty much boils down to one single number: 6. I know, it sounds totally random, right? But trust me, this one little number is the foundation of a super important clinical checklist. They call it the rule of sexes. It's a checklist that a clinician runs through before anything else happens. So the fistula has to be at least 6 millimeters wide, that's to handle the blood flow. It has to be less than 6 millimeters deep under the skin, so you can actually get to it easily. It needs to have matured for at least 4 to 6 weeks after the surgery. And then, when you're actually doing the cannulation, the needles need to be placed at least 6 centimeters apart, and you stay 6 centimeters away from the anastomosis, that surgical connection point. Following these rules is how you know that lifeline is strong, stable, and truly ready for treatment. Okay, section 2, the tools of the trade. This is all about choosing the right needle for the job. So once we're sure the fistula is ready to go, the focus completely shifts. Now it's about the tools. And this is definitely not a one-size-fits-all situation. The needle has to be matched perfectly to that specific patient and their fistula. And basically, you've got 2 main types of needles. You have your sharp needles, which are used for a technique we'll talk about later called rope ladder. They have a sharp cutting edge to create a new path each time. Then you have blunt needles. These are for a different technique called buttonhole. They have a rounded top, no sharp edge. The whole idea is that they're designed to follow a track that's already there, almost like a key fitting perfectly into a lock. Which one you choose is all about the long-term game plan for keeping that fistula healthy. Then you've got to think about the needle's thickness, or its gauge. And this isn't just a random choice. It absolutely has to match the patient's prescribed blood flow rate, or BFR. So if you look at the chart, it's pretty clear. If the blood flow is under 300 milliliters per minute, you can use a thinner 17-gauge needle. But as that flow rate ramps up, say over 450, you need a much wider 14-gauge needle to handle that volume safely. It's really just simple physics, right? You need the right size pipe for the amount of water you're pushing through it. Otherwise, you risk damaging everything. And it's not just about how wide the needle is. The length is just as critical. This all depends on how deep the fistula is. If you've got a fistula that's really shallow, super close to the skin, you need a shorter needle. Why? Because you don't want to poke right through the back wall of it. But if you have a deeper one, maybe on a patient with a larger arm, well, you're going to need a longer needle just to reach the target. I mean, every single millimeter counts here. Next up, we're reading the access. This is the art of assessment before you even think about insertion. So, okay, the needle is chosen, but a real expert doesn't just go for it. Before that needle is ever used, they have to read the access. And I'm not kidding when I say this is an art form. It's a skill that uses pretty much all the senses. And the process breaks down into 3 simple steps. Look, feel, and listen. First, you just look. Are there any visual red flags like redness, bruising, signs of infection, or issues with old sites? Next, you feel. You gently trace the path of the access with your fingertips, and what you're feeling for is a gentle, steady vibration. It's called a thrill, almost like a purring cat under the skin. And finally, you listen with a stethoscope. A healthy fistula makes a continuous, low-pitched humming sound. That's the bruit. And this is where it gets really, really cool. That sound, it's basically a built-in diagnostic tool. If that nice low-pitched bruit suddenly turns into a high-pitched whistling or a pulsing sound, well, that's the check engine light on your car dashboard. It's a huge, flashing warning sign that says, hey, something's wrong in here. It probably means there's a blockage or a narrowing, and it's something that absolutely needs attention right away. All right, here we go. Section 4, the perfect insertion. This is where we get into the science and technique of cannulation. The fistula has been checked out, the tools are ready. Now it's time for the main event, the procedure itself. This is that moment where all the science and technique come together for that perfect insertion. So here's how it goes step by step. First, you apply the tourniquet and disinfect the site. That's standard stuff. Then you prime the needle with saline to get all the air out. Now for the key part. You cannulate at a shallow 25-degree angle. The second you see that little flashback of blood in the line, which tells you you're in the vessel, you immediately flatten out the angle and gently advance the needle the rest of the way in. After that, you take off the tourniquet, tape it all down securely, aspirate and flush with saline just to be 100% sure you're in the right place, and then you do it all over again for the second needle. Now here is a tiny, tiny detail that makes a world of difference. Always, and I mean always, insert the needle's bevel up. What does that mean? It means the slanted opening, the sharpest point of the needle, is facing up, towards you. The easy way to remember it is to make sure the black eye of the needle is looking right back at you. It sounds so simple, but doing this ensures that the sharpest point goes in first, giving you a much cleaner entry and causing way less trauma to the vessel wall. Okay, last section, long-term survival techniques. Because preserving this lifeline for years to come is the real goal. Look, one perfect cannulation is great, but the real challenge, the real art, is keeping this lifeline healthy and working for years, maybe even decades. And to do that, you absolutely have to have a long-term strategy. And for that, there are 2 main methods for long-term health. First is the rope ladder. This is where you rotate the needle sites, moving up and down the length of the fistula with each treatment. Think of it exactly like a farmer rotating crops to keep the soil healthy. It gives each little area time to heal up properly and prevents problems like aneurysms. The other method is called buttonhole, and this one is the total opposite. Here, you use the exact same spot, the same angle, the same depth, every single time. It's like building one perfectly reinforced tunnel that you use over and over. For some patients, this can be a lot less painful. So when we ask, what is this hidden craft that keeps a lifeline flowing? It's not just one thing, is it? It's knowing the rule of 6s. It's the precision of picking the exact right tool for the job. It's the art of using your eyes, your hands, and your ears to read the access before you ever start. It's a really deep and demanding skill that turns what looks like a simple procedure into a true act of care. And that leaves us with a pretty big question to think about, doesn't it? In a world of medicine that's getting more and more automated, how do we make sure that this essential human craft continues to be taught, to be valued, and to be mastered?